fine, they're not going to necessarily see that. And then it's a bit too late, they've already been hospitalized for a decompensation. But if you look at the slope toward rehospitalization for decompensation in heart failure, there are some early signs. Internally, filling pressures in the heart and lungs, they start to rise early before they clinically manifest themselves with symptoms. The autonomic system starts to adapt to that. Intrathoracic impedance starts to rise. These are not things you're necessarily going to detect, or the patient may not detect when they're busy in their lives. And then, of course, the gold standard that we all use, the poor man's scale at home, is, well, call me if your weight goes up 3 or 4 pounds. I mean, maybe they ate a big meal. You know, maybe they weigh themselves one day on this scale and the next day that scale, and at different times and different clothes. That's really what we often go by. And sometimes it works decently well, but by the time that happens, you're too late. By the time their weight went up 3, 4, or 5 pounds, you may be too late. They may already need to be admitted, or at least you're going to have to really slam them with higher doses of diuretics, which then could lead to renal dysfunction, low potassium levels, and other side effects like that. So is there a way we can detect these changes earlier, before their weight goes up 5 pounds? Well, we do have evidence that invasive cardiac pressure monitoring, intracardiac pressure monitoring, does show us that as those pressures start to rise, which is an early part of the slope, that's when heart failure events are predicted to occur, or are going to occur. Can you intervene sooner? Well, up till now, the only way to measure those internal pressures was either by an echocardiogram, which gives you an estimate. It's not always perfectly accurate, but it gives you an estimate of their filling volumes and their pulmonary artery pressures, which we use. But today, we now have the CardioMEMS implantable tiny little sensor that is implanted into the pulmonary artery. It sits in the pulmonary artery and just stays there. It's just pretty easily implanted through in the cath lab through the groin. It's not an open surgery or anything. Takes 45 minutes or so. You just go into the pulmonary artery, you just deposit this thing, and it kind of just lodges there, and it just gets lodged there and stays there. And then the patient goes home, and with this device at home, they put under their pillow, they just lay on it, and the numbers, the pulmonary artery pressures, get directly transmitted back to the physician as often as you want to do this. So you can be tracking their pressures every day, or as often as need be, and you're really getting invasive hemodynamic monitoring.
Do you have to be on anticoagulation if you have that in?
Great question. No. No.
Can you just repeat it, say a sentence, because it won't be on the camera?
About the anticoagulation?
Yeah. Can you put
No,
that
this
in a...
this device is very, very small. It sits very distal in the pulmonary artery and does not require any long-term anticoagulation for it.
Thank you.
And it's it's already been implanted 10,000 times around the world. Knock on wood, seems to be a very safe, very, very safe device, very safe procedure, and gives you a lot of great data. Well, in their landmark trial, the Champion trial, they randomized people to either just usual treatment, monitoring your weight and being on medications, to the treatment group, which was getting this device in addition, of course, to usual heart failure therapy. Remember, this is a device that gives you information. This is not a treatment device, right? It's not eluting a drug or anything like that. This is giving you information for hemodynamic monitoring. The question is, do you know how to use that information? Because it's fancy and impressive and expensive, but can you use it and make an impact clinically? Well, they really did. Not only did you see it after their initial 6-month endpoint, but with a 28% reduction in heart failure, hospitalizations for heart failure. But the FDA said, before we really give approval, you got to extend this out a couple of years. We need to see if this is really clinically, when you put it into clinical practice in the world, are we really seeing less hospitalization? And it only got better. The further out you went, the more people implanted, the more they got comfortable implanting it, and the more you learned how to use it. And it came with a protocol of what to do when the pressures start rising. The patients do not see their pressures at home. And that may be something to discuss in the future. Should they see it at home? Is that going to help or hurt? by the doctors or the nursing staff or anyone, nurse practitioners, anyone in the healthcare. They're the ones who have access to it. And then they follow a protocol of, well, looks like your pressures are rising. You may need to increase your diuretics. You may have room to increase your afterload medicines like ACE inhibitors. And so you're really managing their medicine still, but you have an invasive monitor of it. What I really want to point out, and this is what's really unique. As I mentioned, we don't have any evidence-based treatment or treatment strategies for heart failure with preserved ejection fraction. But in this trial, they did include patients with heart failure with preserved ejection fraction, although the majority was still reduced ejection fraction. In a sub-analysis, they did show that in patients with HFpEF, heart failure with preserved ejection fraction, you had a 50% reduction in heart failure hospitalizations. Again, this is because it's not treating the disease, it is helping the physician and the patient treat the patient and adjust your medications appropriately. But this is really big news because it's really the first and only thing we really have to offer for patients who are getting admitted for heart failure with normal ejection fractions. I want to just mention one other additional type of invasive monitoring, but really to illustrate a different point. And that is, I mentioned that along the cascade before weight starts to really rise is increased intrathoracic impedance. Now, people who have defibrillators can actually have this measured, not all of them, but some defibrillators have the ability to measure intrathoracic impedance. When that starts to rise, you can see it's associated with adverse events. And as the index rises above 100, clearly you see there's a big difference. But again, does this translate into clinical practice? And there was I can't remember if I put this slide, I think I left this slide off, but I'll just tell you about it. There was a trial to look at how this would work clinically, the DOT-HF trial. What they did was, the people who were part of the intrathoracic impedance group, they had a beeper, not a pager. The device would beep when the intrathoracic pressure went above a certain level. So it would notify them, oh, your pressure's. And the other group didn't have anything telling them. Well, guess what happened? Which group do you think had more hospitalization? The people with the beeps. Because they'd freak out, call their doctor, my thing's beeping, and they'd say, oh, you better come in or go to the emergency room. And it translated into more hospitalization. So the point is, while it's great that we have these ways of invasively measuring early signs of decompensation, we have to know how to handle that information, what to do with it so we could translate it into clinical practice, keep people out of the hospital. I want to shift a little bit away now from medications because unfortunately medications, while they're great and have excellent outcomes overall, we still have such a large population that either didn't get medically treated properly or they did, and unfortunately the natural history of the disease sometimes is things just get worse. Well, there are a lot of strategies one can still implement beyond just medications. I just want you to know about some of the things. First of all, I mean, just at Cedars-Sinai, for example, we have an advanced heart failure unit where people who are decompensated, they can be in a hospital, walking around a regular unit, not an ICU, with inotropic medications, with Swan-Ganz catheters, measuring things. People who have structural heart disease, but they're too sick to have surgery to fix this kind of valve. We have minimally invasive or percutaneous approaches that I'll show you about in a second to fix valves or replace valves. We have the CardioMEMS device. If you have unique conditions like pulmonary hypertension, we have a center and specialists for that. Amyloid, hypertrophic cardiomyopathies, these are unusual cardiomyopathies that do not follow the book. You can't treat these the same way as everyone else. And then a lot of trials we're involved in with either medications, devices, but also a lot of stem cell trials and learning how to give stem cells. Do you inject it into the myocardium? Do you put it down the coronary artery? Does it work in ischemic patients who are all scarred down, or can it work in non-ischemic patients? And we have yet to see the results yet, but we have a lot of trials ongoing. I want to mention this because this is really hot off the press, just as of a few weeks ago, in the end of September. Well, unfortunately, as the heart starts to either get weaker and more dilated, the mitral valve apparatus starts to stretch, and these valves don't coapt very well together, and then you get this leakage of blood backwards called mitral regurgitation, a very common finding that we see in heart failure. Well, there's now this percutaneously placed clip. Again, it's just done with a poke in the groin in the cath lab, where you go up to the heart, you cross the septum, and you put this clip onto the mitral valve leaflets and grab hold of them. And then you leave the clip there and you take everything else out. And we just now got the results of this trial called the COAPT trial. And the results were even better than we expected, to be honest. I wasn't sure I even believed it when I first saw it. But we were involved in this trial. And you saw a really significant reduction in hospitalization for heart failure. You can see how early on the curves separate and what a reduction this is. But in addition to this, even a reduction in death from any cause. I mean, these were really incredible results because a lot of these patients are at the point where people think, well, there's nothing you can do anymore. Your ejection fraction's, 25, 30%. Of course you have mitral regurgitation, everybody does. We can just raise your diuretics. But actually we have proof that in the right patients, at least, that are candidates for this, you might really be able to help them. Of course, none of these are curative. These are all Band-Aids, to prolonging life and getting them, but they may ultimately not do well. When all else fails, in most things in life you can get away with eating chocolate, but unfortunately when all else fails in heart failure, when all else fails in heart failure, things can get very grim and very fast, and you can really, this illustration shows you can be walking along thinking everything's quite okay and straight, and then you really can drop off the curve and things can crash pretty quickly. For the last part of the talk, I'm going to focus a little bit more on what we do in terms of advanced heart failure management. These are people that are beyond just medication, just beyond an ICD. They have all that, but the heart is failing even more. And what I want to emphasize here is these are the signs physicians need to be aware of, they need to look at. Our patient in the beginning had some of these signs. When you start getting hospitalized, when you start to see rise in your BUN or creatinine, your renal function, your appetite is not as good. You can't tolerate the same dose of medicines that you've been on for so long. You start getting ICD shocks. Even if you feel fine afterwards, these are poor prognostic signs. These are signs that things are getting worse. You need to be referred to, you need to have somebody who's well adept in the field of heart failure. Well, what kind of a person needs a transplant? Because we get this question all the time. I know someone whose ejection fraction is 10%. I got to send them to you. They're going to drop dead. Well, the truth is, it's really for patients with unacceptable quality of life or unacceptable high risk of sudden death. And the truth is, you have people out there with ejection fractions of 10% who are running every day for an hour. You'd never know it. You'd never know. They're asymptomatic, they're incredible. I just recently got a young kid in his 20s, who lifts weights, he looks amazing. I hate when he comes to the office because he's wearing a tank top, he makes me look like an idiot. But he's well built, and you'd never ever know. You'd never ever know. But it's when it gets to a point of clinical deterioration where your quality of life is that bad, we really have to intervene. And in the same vein, we're always talking about heart transplant at the same time as mechanical circulatory support, and I'll give you just an idea of what this really means. If we say there's about 370,000 people who reach this New York Heart Association class 3B to 4, which is highly, highly symptomatic, very poor quality of life, even just getting dressed and doing your daily activities. Only about 100,000 of them are going to be heart transplant candidates. For various reasons, they may not be. They could be too old. They could have too many comorbidities. They could have malignancy, God forbid, or something that you cannot be on immunosuppression for. It's also very important to recognize that there are a large number of patients who are going to have to go the route of palliative care. And palliative care is an important intervention, and it's not just giving up on people. Many people just say, I'm sorry, there's nothing I can offer you. For people who have nothing that you can offer them, you can offer them palliative care. There really is benefit to those people meeting with palliative care doctors or nurse practitioners or anyone on the team. We do it all the time. It's part of our procedure. But if you say it's about 97,000 who are going to go, who are waiting for, of these patients who cannot wait, if they can't wait for a heart transplant, I apologize, 100,000 heart transplant candidates. We're still only doing in America about 23 to 2,500 a year. That hasn't changed in a long time. We're really limited, obviously, because you don't have hearts on the shelf. So, but you do have machines on the shelf. They may cost a lot of money, but they're there. So what about the 97,000 patients who are waiting for a heart transplant? Can they make it? How long are they going to wait? Of these patients, let's say you have about, I think in the US about today, we're doing about 2,800 LVADs and 200 TAHs, which is total artificial hearts, and I'll show you what that is. An LVAD is a left ventricular assist device. I'll show you what that is in a second, but it's a pump that you attach to the heart. Dick Cheney had it for his transplant. And a total artificial heart, you actually take out the heart and put it in a machine. But as you can see, we really have a problem. There are just so many people who are waiting, and they may not make it. Still today, the most durable treatment for real end-stage heart disease is heart transplantation. And it's really, some people don't realize it's taking out your heart and putting someone else's heart in, someone who's already been declared brain dead. Last year was a very landmark year because it actually marked the 50th anniversary since the first heart transplant, which was done in South Africa by a surgeon named Christian Barnard. And this was the patient named Louis Washansky. I have a bit of personal tie to it because my father is from South Africa and trained at that hospital, and my grandfather knew Christian Barnard. And unfortunately, they didn't have the expertise of how to manage a patient after heart transplant with immunosuppression, and it's an art form. It's not just science. He succumbed to pneumonia 18 days later and died. But the proof of concept was there. You can put a heart in another person and it can work. If you look at the rise in the number of transplants done throughout the world, right about here was when you had the inclusion of immunosuppression medications like cyclosporin. When that became used, a calcineurin inhibitor, cyclosporin, you really saw a huge rise in the number of transplants, not only in the US, but also, or North America, but also around the world. Tailored off a little bit over time, but it really hasn't changed that much. The supply is limited, obviously. It really hasn't changed that much up till today. We're very fortunate at Cedars-Sinai, and I was very lucky to be training at a time when this group came to Cedars-Sinai. But just to give you an idea of how many we do at Cedars-Sinai, most programs around the country are doing something around 30 to 40 transplants a year. So we really have the benefit of seeing over 100 patients a year getting transplants. And we get referrals from all over the world, really, because of expertise in how do you use immunosuppression. What about patients who have a lot of antibody levels that are high? What are patients that are very, very high risk and they won't be accepted anywhere else? And as I mentioned, this is still the most durable form of therapy for end-stage heart failure. The median survival is still about 11 years, but most complications will occur in the first year due to infection or rejection. So if one can survive the first year, actually, then the median survival actually really goes up to 13 or 14 years, which is really quite amazing considering these people probably would have died. They probably would have died very soon. And the quality of life you can return to them is something that's you can't put into words or numbers. But it's not a walk in the park. This is not really an exaggeration to what it's like to live with a heart transplant. There are a lot of medications that one has to take, and a lot of them are essential medications because you miss a day or two of immunosuppression, you can go into rejection and die. And so you have to tell, and that's why when you find patients and you're looking into their candidacy, compliance, social support, those are sometimes the biggest reasons we have to decline someone for transplant. If you can't show compliance and you can take your medications, come to appointments, come to get biopsies, Biopsy is a rather routine procedure we do in the first year, about somewhere between 10 and 14 times during your first year. And it's pretty simple, going from the neck, usually, into the heart, take a couple pieces, and go and analyze them for hidden or silent rejection. But it's not a walk in the park, and there are a lot of challenges. I mentioned rejection and infection early on, but later on, you start to see complications from long-term immunosuppression. And hopefully you don't, but sometimes you see malignancy or something called cardiac allograft vasculopathy, which is basically coronary artery disease building up in the transplanted heart. And long-term immunosuppression carries with it side effects like diabetes, hypertension, renal insufficiency. I just wanted to show this. I wish I could get it to play, but for some reason I always have a problem with that. And one of the challenges in heart transplant is how do you find a donor that's close enough that you can go there, get the heart, put it on ice, and get it into the new person within 4 hours or so.
Wow.
And we're limited right now because of geography. You can't just, if a heart matched you in New York, there's nothing you can do about it right now. However, we've come up with a beautiful system, although, well, it has its challenges too, but it's called heart in a box. And what you do is you take the heart out of the donor, you attach it to this apparatus, and run blood through it. And it starts beating. And you're just standing there, there's a beating heart in this box, and in theory, you can take it anywhere in the world now, right? And it's beating, it's warm, it's perfused. And so, for certain cases that we've used that. But what if you can't wait? What do you do when you just can't wait for a heart transplant because it's going to take too long, or if you're not a candidate for one? Well, mechanical circulatory support is a huge part of what we do. We're very, very involved, of course, with surgeons because these are surgically implantable devices for the most part. This is what one of the most common left ventricular assist device looks like. It's surgically implanted. You stick this cannula into the apex of the heart, and then the blood comes into the heart through the device, and the device has a motor that's spinning and pumps that blood into the aorta. So you're basically kind of bypassing the weak ventricle. On the other hand, some people can't get away with just a left ventricular assist device. Their right ventricle is also completely failed, or other reasons as well. They need a total artificial heart. Just one disclaimer, most of their abs do not look this good in our patients, and that's not me. So just quickly I know we're going over time, but just a few words about mechanical support. As I mentioned, it's really, really important to stay on top of these patients because they can kind of be moving along for a little while, slow decline, but they can rapidly drop off at a certain point. And the problem with that is that we lose patients lose opportunities to go for transplant or mechanical support because it's too late. And this slide is not a joke. You have to really be sick enough to need this kind of therapy, but you can't be that sick that you can't make it through the surgery. And families all the time say, well, do something. He's dying, do something. Believe it or not, you can be too sick for a heart transplant. You can be too sick for a mechanical pump. And when somebody presents in cardiogenic shock, there's a few ways you can go. Oftentimes you get people sometimes coming in, crashing through the door. We don't know anything about them. We don't know if they're compliant. We don't know if they're drug users. We don't know if they're, if they have support to get one of these devices. So some of them end up as getting devices or mechanical pumps as a bridge to transplant. Some get it as destination therapy, which means they're just going to live the rest of their life with it. They're not candidates for transplant. Some get it as a bridge to recovery. There are some conditions that I mentioned where their heart's failing, but it actually might recover. And if you give them a few months on an LVAD, they may be able to remove that LVAD. And then there are other people who we don't know what's going to be with them, and so we put in a temporary device usually to kind of keep them alive until we can make a decision. Some of the temporary devices we use, intra-aortic balloon pumps. Impella is a very common device we use, which is basically a temporary motor LVAD that sits on the end of a catheter, and I'll show you a picture. We don't have great support yet for right ventricular failure. We have different things, but it's not simple. It's surgery, and it's if they need that, they're very sick. And Ecmo, which is basically cardiopulmonary bypass. The Impella is a catheter just like this. It can either be put in through the groin, or in through the axillary artery up here. And it's a temporary catheter, just sits across the aortic valve in the ventricle. And this little thing here has a motor, and it sucks up blood and spits it out over here. It's like a mini temporary LVAD. This is what an Ecmo looks like. It stands for extracorporeal membrane oxygenator. And basically, this is how you hook this up to a patient. You take their blood out of their body, put it through the machine, give it oxygen, so if their lungs are not working, they can still get oxygen, and their heart, you can pump it back into the body. As I mentioned though, the durable devices, these are the ones that patients can actually go home with and either live for many years or live until they can get a transplant. All of this is internal. You know, they open the chest, they close the chest afterwards, and the only thing that's coming out of the body comes out around here, the drive line, and exits the skin in the abdomen, and it's attached to a controller and 2 batteries 24/7. So they have to be able to carry around these things. And the artificial heart, as I mentioned, you take the heart out completely, you put in this machine, and everything's internal. Only coming out of the skin are these 2 drive lines attached to this. Basically, it's like a backpack you can wear with this machine that's continuously pumping. And people go home with this. They can live. We've had a couple patients live for a couple of years with this device. This is an example of the HeartMate 2, which was a really revolutionary pump that was continuous flow, meaning our natural bodies get pulsatile flow. That's why we have a pulse. These patients don't have a pulse. And so they go into an emergency room, I mean, they don't know about it, they're looking for a pulse. And then we've made some great advances over the last few years, though, in trying to come up with better techniques, better engineering. And this is a magnetically levitated rotor inside the pump so that there's much less friction, and therefore you decrease the chance of forming clots. And one of the big challenges is blood clots that form. So this system is spinning in mid-air because of magnets around it. Just to show you there's great data on quality of life and clinical improvement. This is medical therapy arm, this is an LVAD arm. They both started with very symptomatic heart failure, class 3 or 4 in both groups. But at the end of the trial, okay, at the end of the trial after 12 months, only 29% of this group made it, improved their New York Heart Association class of symptoms, whereas in this group, 77% said they did. Survival benefit overall at a year is about 80%, which is really quite something, because you're talking about an alternative of 15 to 20% survival. We still deal with a lot of challenges though. If this, if there was a way to just take everyone with a failing heart, put in a pump and go home, that would be amazing. But we deal with stroke. It's an unacceptably high rate still, 10% about. Hemorrhagic because they're on blood thinners all the time, they have to be. And also ischemic strokes. Another problem is because they're on blood thinners and non-pulsatile flow seems to increase AV malformations in the gut, which makes you more prone to bleed, so we get GI bleeding all the time. And infections, because you have this drive line coming out of the skin all the time. Someone has to keep it clean and make sure you don't get infections. So just to end off with some great pictures, because really, it's not just about keeping people from dying, it's allowing people to live. We don't want them to just be alive, we want them to live. And this was our longest standing LVAD patient in more than 7 years. He traveled constantly. Maybe you could find a little bit better sweater, but it's hard to even tell he has a device. You can't even tell which of these people has an LVAD. They're out there enjoying life. I can't say we recommend this type of activity with an LVAD. And then finally, the total artificial heart is a bigger surgery, it's a bigger deal. Of course, once they have an implantable artificial heart, if that thing stops, it stops. There's nothing you can do. But we use it for conditions like hypertrophic cardiomyopathy, amyloid, where the heart is too thick. You can't fit an LVAD in that heart. You need to take the heart out and replace it. And sometimes intractable arrhythmias. And here's 2 different patients. We used to have one size fits all, but we actually now do have a second size pumps. And these are people who do not have hearts in their chest. Here's a guy just enjoying a Dodger game with Dodger Yasiel Puig. And you know, these are live patients who are out there living life, running Ironmans post-transplant, climbing the Matterhorn. But I really got to say, you know,